Magandang gabi sa inyong lahat. That is just putting light into my topic tonight. And for all of you, I am sure you know this guy, who this guy is. He is Stevie Wonder, who was born in Michigan in 1950, born premature, and developed retinopathy of prematurity. That's why he became blind. Now, his blindness did not stop him from moving on, but as early as 8 years of age, he became a skilled musician. And so that in 1984, he wrote the song, I just came to say, I'm sorry. And that song won the Oscar Awards in 1984. That is a story of Stevie Wonder, but it's not the same for all infants who develop ROP. And this is my topic this afternoon. Tonight, I'm going to discuss retinopathy of prematurity, the preventive care plan strategy for 2020. This is a project, a joint statement between the Philippine Society of Newborn Medicine, of course under the umbrella of the Philippine Society of Pediatrics, with the Academy of Ophthalmology and the ROP Technical Working Group. I'd like to reiterate that this is not a clinical practice guidelines, but it's not because the clinical practice guidelines or CPG will require a more tedious process and a different process of development. But this is a joint statement between these two societies. And the goal, which is actually the goal and objective for tonight, is to reiterate the significance of retinopathy of prematurity in premature infants so that the physicians who are taking care of premature infants, up to date, to this day, there are only like 137 neonatologists in the Philippines. And we cannot, together with the ophthalmologists, we cannot definitely shoulder the responsibility. I know that there are a lot of gen peds who are taking care of premature infants. So we would like you to be on board to prevent this devastating illness of retinopathy of prematurity and its sequelae, which is blindness. The incidence of ROP is actually increasing. There are about 50,000 babies who are blind as a result of ROP. And the increased incidence is for secondary to increased survival. We have improved our technology in the care of premature infants. We have the ventilators, the availability of surfactant, the use of antenatal steroids have all contributed to increasing survival. But as a result of that, we have more babies who are at risk, premature babies who are at risk of developing ROP. And then I think the improved awareness and the implementation of guidelines on ROP has increased the apparent increase of ROP in the Philippines. As I mentioned earlier, ROP is actually preventable because we now have better oxygen monitoring. The pulse oximeters have become very affordable, available even in the district hospitals and even clinics. So there should not be any reason why we should not monitor the oxygen levels of our patients, especially the premature infant. Prevention of systemic diseases like sepsis can also help decrease the incidence of ROP. And again, this is very important, early diagnosis and treatment. Because when you catch this baby during the early stage of ROP, then we can prevent blindness associated with the disease. So what actually is retinopathy of prematurity? Retinopathy of prematurity, ito, tinatanong ko sa resident ko a while ago, and I said we always keep on talking about ROP, but do we actually know what it is? It used to be called retrolental fibroplasia in 1940s by Terry. Then thereafter, it changed to retinopathy of prematurity. So it's actually a developmental order, disorder of the vascular bed. It's proliferative, meaning it's not static, of the retina of premature infants. So these are the keywords when you talk about ROP. It's a vascular problem, proliferative, the retina of premature infants. In order for us to understand the development of ROP, it's very important to know the sequence of vascularization and the anatomy of that. I will go through this very briefly. I will not bore you with a detailed anatomy, but we know that the retina in utero is avascular. These blood vessels are not present. This is actually a sagittal section of the eye, and this is where your optic nerve, and somewhere here is your macula. So the optic disc and the macula. So this area is avascular at birth, and then the growth of blood vessels will actually arise from here at the 16th week, and it goes peripherally at that, so that the anterior segment of the eye is supplied by a hyaloid artery, which travels from here supplying this. But the artery is resorbed by 34 weeks gestation when the retina is already hopefully vascularized. So this is actually a video which will tell you that in utero, the retina is avascular. This is the macula, this is the optic disc, and the vascularization starts from here. And then it goes peripherally again. So the nasal part is by around 32 to 36 weeks, the nasal part of the retina, and then 40 weeks on the temporal side of the retina. I'd like to show you this normal retinal development. At 16 weeks, this is how it looks. On fundoscopy, those are the blood vessels. And at 32 weeks, then a portion of the temporal retina is not yet vascularized. And then by 40 weeks, this is how the retinal vascularization should look like. And then this is very important because the retinal vascularization will tell you that at 16 weeks, where it's here, then the retinal blood vessels will grow, reaching at the ora serrata, which is the edge of the eye, at 36 weeks on the nasal side. So this is what? The left eye or the right? Left eye, right? So this is the nasal side. So it gets vascularized earlier, whereas on the temporal side, it reaches about 36 to 40 weeks before vascularization is complete. The numbers in the figure will tell you the weeks of gestation. Why is this very important? So that when you get the baby who is 36 weeks old or even 24 weeks, you know how far the vascularization is. 32 weeks here, and then as you progress. So this will help you visualize the degree of maturation or the vascularization of the infant that you are receiving or handling, managing. So the pathophysiology of what actually happens in ROP, as there is vascularization, what happens if the baby is delivered for example, a 24 weeker, a 32 weeker, then when there is an insult, which can be hyperoxia, hypoxia, hypotension, and this will lead to vasoconstriction and decreased blood flow. The vasoconstriction as a result of these insults will lead to this increased blood flow, and there is arrest in vascular development. And as a result of that, the hypoxia can actually affect the presence of the substances which are pertinent in the understanding of therapy later on. But just to mention so that you can be aware of it, nice to know actually. But there is an imbalance between the VEGF, which is actually the vascular endothelial growth factor, and the IGF-1, which is the insulin like growth factor. An increase in the hypoxia will actually lead to increased VEGF and a decrease in IGF, which favors retinal development. So, as a result of those insult in the retina, there is neovascularization. There is growth of new blood vessels, which are actually very permeable. Hypoxic avascular retina, I mentioned earlier, upregulates the production of vascular endothelial growth factor. And then the peripheral retina becomes more permeable. If you become permeable, then you have what? Edema, hemorrhage, and that will lead to fibrosis. Remember, when you have neovascularization, it doesn't only grow in the periphery, but it also grows inside towards the vitreous body. And the fibrosis and the edema and hemorrhage will bring about traction of the retina, which is plastered in the ball inside the eye. So the fibrosis will produce traction, and it will lead to retinal detachment in the infant. This is my next slide, which will tell you what exactly happens in retinal detachment. So these are the blood vessels. And then because of the hypoxic insult, hypotension, then there is arrest in the growth of the blood vessels. And you will see the thin line, demarcation line, which is stage 1. When this one thickens, it becomes stage 2. When you have proliferation of blood vessels, it's stage 3. And then the blood vessels will not actually just go in progress towards the periphery or the retina, but it also traverses. They also go through the vitreous body, and this will put a traction because of the fibrosis. It will have traction on the retina, which is attached to the globe, and then producing retinal detachment. So this is actually a partial retinal detachment. It can actually involve the whole retina of the eye, leading to stage 3 retinal detachment. Just for you to imagine, I'm going to show you the fundoscopic findings of our ophthalmologists during the. So this is stage 0. This is the developed retina and the premature retina. So you can see that the premature retina, the vascularization is not complete. So this is the vascularized area, and this is the avascular area. So as the infant grows, it's expected that the growth of the blood vessels will go towards the periphery. Okay, but what happens because of an insult, hypoxic insult, hypotension, then there is arrest in the growth of blood vessels. So this part of the retina will remain avascular. So this is the thin demarcation line, which will progress to stage 2 ROP. Stage 2 ROP, you can see that the demarcation line has become a ridge, thickened, and you see here you can see the ridge getting thickened, and the arcading is how it is described of the blood vessels. So again, this is still the retina, which is avascular. So that's stage 2 thickened ridge formation. Stage 3, when you have fibrosis, hemorrhage, edema, in proliferative vascular proliferation, which is very characteristic of stage 3. And stage 4 is what I showed you, when you have a retinal detachment, which is partial. Stage 5 is when you have retinal detachment. Okay, when do we screen ROP? Different societies have actually given guidelines, different guidelines, but as I talk as far as our society and the Academy of Ophthalmology, that we recommend screening when the baby is delivered less than 28 weeks. Then ROP screening has to be done 30 weeks postnatal age. For those who are delivered more than 10 to 28 weeks, then you have to have the baby examined 20 days postnatal age or prior to discharge. what we do in our unit is we examine them 20 days after delivery. I mean, we order for our OP, and we at least we have a relatively good working relation with our Department of Ophthalmology and prior to discharge. The follow-up will depend on how severe the ROP is. Okay, so it will be just a schedule depending on the severity of the ROP. But so far, since we have been doing ROP in our unit, I have yet to see a baby who has retinal detachment. I have not heard of like stage 3 or even 2. So what about the risk factors? The most important risk factor, which cannot be overemphasized, is prematurity. Less than 32 weeks, the birth weight of 1,500 grams. I'm sorry, that should be 1,500 grams. And if you have gestational ages between 32 to 36 weeks, with the following risk factors, which are what? Sepsis, transfusion, less than 10 days due to anemia, oxygen use without oxygen blender, and premature with unstable course. So sepsis is very common so that can be a factor for ROP, transfusion, and oxygen use without oxygen blender. We don't have an oxygen blender. I mean, not all hospitals uh, have oxygen blenders. So what we actually do in our center is we wide the compressed air and the oxygen. But even other hospitals, they don't have compressed air. But lately, just to support our babies, we have been maintaining just 21% oxygen, and they do well just to prevent the apnea of prematurity. So the acronym you have to remember: STOP, S for sepsis, T for transfusion, the oxygen without the blender, because we recommend saturations between 90 to 95% FiO2, and then the P for prematurity with unstable course. Now, for resuscitation, immediately at the delivery, we recommend 30% oxygen. If you don't have a blender giving 30% oxygen, then you can do your bag valve ventilation without the use of your corrugated tubing. That will roughly give you around 40% of oxygen. And for those who have pulse oximeters, let us remember that you do not achieve a good saturation immediately. And it's at 1 minute, it's what, 60? It's easy to remember. 60 at 1 minute, 65 at 2 minutes, 70 at 3 minutes, 80 at 4 minutes, 85 at 5 minutes, and then 85 to 90 at 10 minutes. So 60, 65, 70, 75, 80, and then 85 to 90 at 10 minutes. So the babies are actually not saturating well immediately after delivery. So do not be on your toes if they're not saturating well until that period of time, unless they're limp and apneic. Okay. So I am in my next last slide. Is let us remember that ROP is caused by prematurity. And remember the figure I showed you that vascularization starts at 16 weeks, going towards 32 weeks at the nasal area, and then later at 40 weeks at the temporal area. So it's actually the prematurity which is the problem, and oxygen is just one of the several important factors in the ROP. I would also like to emphasize that when you have your babies examined, they inject topical anesthesia, something to dilate I think it's phenylephrine to dilate the pupils. So that can produce desaturation, arrhythmia, and gastrointestinal effects like emesis. So in my experience, we ended up intubating the babies post ROP screening because of the problems of this. So you have to monitor them. They ended up getting ventilated because of after the examination. So babies have to be monitored after. This is, I would just like to show you the international classification for ROP so that when the ophthalmologist will tell you stage 1, stage 2, zone 1, you know what he or she is talking about. Zone 1 when it's in the periphery of the macula and the optic disc. Zone 2 is the outer zone, the yellow one. And zone 3 is the remaining periphery of the eye. So usually if there is ROP or stage 1, 2, 3 in the zone 1, which is the most important area of the eye, then that warrants close monitoring. And we talk stage 1, 1 is just the demarcation line, 2 is for the ridge formation, 3 is the fibrovascular proliferation, 4 is partial retinal detachment, and 5 when you have full retinal detachment. So what are the therapies? Very short. They are now using, they've been using intravitreal injection of anti-VEGF agents. Remember I said earlier, the hypoxia brought about by the insults, hypotension and everything will be upregulates, lead to increase vascular endothelial growth factor. So now they have used agents which will counteract the effect of your VEGF. So that's why installation inside the eye of agents like anti-VEGF agents. So that's one therapy. The other is laser photocoagulation, which they do in order to prevent retinal detachment. So the timing of ROP, it should be done less than 28 weeks. For patients who are 28 weeks and below, 31 weeks postnatal age. For those who are delivered more than 28 weeks and above, actually, this is a repeat slide just to emphasize. So if you have a baby 28 weeker, you have to do the ROP screening at 31 weeks. But if you have a baby who is more than 28 weeks and above, ROP should be done 20 days after delivery and at the time of discharge. The follow-up will depend on the findings of the ophthalmologist. I'd like to end with this slide, that no baby deserves to go blind from ROP. So this is actually a team approach. Our experience is, especially my experience, we order, I tell my residents to do it. I don't know whether it's being done or not. So if us, neonatologists, pediatricians, will order, ask the residents to order, no, and then the nurses will become aware of the devastating effect of ROP, then we will be on our toes of monitoring these babies. We also, and then when you order, it's very important that you have to document it in the chart. In the US, this is one important cause of litigations, especially when the baby will end up blind. And again, you have to tell the parents of the risk of ROP in premature infants, so that in the event that it happens, then more or less they know. But we don't like that to happen. By being aware of the possibility of ROP in babies who are premature, less than 32 to 36 weeks, with unstable course, with the stop, with sepsis, transfusion, oxygen, and premature, they should have an ROP clearance. Whether they need to continue following up with the ophthalmologist will depend again on the ophthalmologist. I usually refer them, and the ophthalmologist will just be responsible of when they should go back. Okay? But at least you have referred. I'd like to tell you that in my practice, I saw a 3-month-old baby who was delivered in Bulacan, and there's no fixed fixed gaze. The baby cannot even regard. So the baby was born premature, and the baby had retinal detachment. So it's a very sad story. So I'd like to enjoin everybody to be aware of this, to be involved in the care of premature infants by having them check for retinopathy of premature. Maraming salamat. Thank you very much. Thank you very much for this activity. This is a manifestation that despite the pandemic, there is life outside COVID, and we should not overlook the continuing problems of our patients like prematurity and its associated retinopathy of prematurity. Thank you.
Thank you very much, Dr. Adesis, for that presentation. Actually, for the information of everybody, the joint statement of PSNBM and PAO was only released last August 17. So this guideline is new to us as well. Now, we would like to welcome again Dr. Neil Alviedo to talk on bronchopulmonary dysplasia and postnatal corticosteroids.